minutes past 3. We should probably. So, welcome everyone. Welcome, Raja. As you all know, we are here to hear Raja's presentation for his PhD thesis. You will have 45 minutes to entertain us. And then it will be the jury that will be entertaining you. And as a jury member who should be joining very soon, we have Professor Bharat Biswal from NJIT in the US. I hope he can join us mid-presentation or as soon as possible. We have also another external member, Professor Daniele Marinazzo from University of Ghent. I'm going from left, Professor Roland Steens from the Faculty of Medicine, CHU, and also GIGA CRC.
What happened is
Professor Athena Devici from the GIGA imaging as well. Professor Olivia Boussery from GIGA Consciousness. Mohamed Barry, Professor, or Dr. Barry, Professor as well. It's written Professor in the manuscript. From the GIGA CRC Vivo Imaging, the two supervisors of the projects were Hikta Annen and
so first I go to here,
Dr.
then
Annen and Professor
here,
Stephen Loreis from GIGA Consciousness.
then here,
And I'm here to chair the meeting. Philips, also from GIGA CRC Imaging. And well, I hope you can start your presentation. For yours, you've got 45 minutes.
Thank you, respected President, jury members, all committee members and colleagues. All committee member, you have been helping me in the all my PhD journey from last 5 years, and your suggestion and comments make the sake of my PhD work. I also extend my sincere thanks to my supervisor, Professor Dr. Stephen Loreis and Dr. Jitika Anand, for guiding me and helping me whole journey. It was a great learning curve for last 5 years to understand the mystery of consciousness. I also thanks my all colleague from Coma Science Group and from the GIGA Consciousness, friend and family. My PhD work is on multimodal, empirical, and computational modeling for mechanistic explanation of altered state of consciousness. Consciousness is what we everything what we experience, and measuring or and explaining in the scientific aspect is quite challenging. However, in the clinical practice, we need a quantitative measure to express or to assess the consciousness. One straightforward approach is to look the bottom-up approach from to assess what are the minimal requirement for consciousness at loss of consciousness, or assessing the loss of consciousness. Indeed, in the daily life, every day we lose the consciousness naturally through sleep. So the two main or a simple assessment is to two-dimensional approach of clinical assessment, which says that during the loss of consciousness, our awareness and awakeness reduces. The arousal and awareness get reduces. And when a person is faced with a brain hemorrhage or accident, patient lose the arousal and awareness, and this state called coma. Another is through a drug, patient or a subject also lose the awareness and arousal due to the anesthetic drug. So the patient who lose the awareness and arousal, slowly they recover the arousal. And if the patient doesn't show any behavioral awareness, then it's called vegetative state or unresponsive wakeful syndrome. So in this condition, the patient have a arousal but doesn't show any behavioral responses. And when the patient have regained some awareness or behavioral responses, is called minimal conscious state, minus or plus, depending on the language dependent. If the patient doesn't show any language responses, it means is minus, and if the patient show behavioral response with a language, it's called minimal conscious plus. And to be noted that some patient of UWS and at the bedside doesn't show behaviorally any response or any behavioral response, but their brain have a certain neural activity which shown by neuroimaging methods. And this group called as MC star. This indicate the behaviorally what we measure, the it's not directly represent the conscious level. In the PhD, I more focus on the group of DOC patient, that's the UWS, MC-star, and MSHIS patient, to aim for the conscious process. There have been many studies carried out in the context of disorder of consciousness using neuroimaging methods, and it's been shown that the brain metabolism gets reduces. So you could see here in the PET, FDG PET, the healthy subject, and they have a higher metabolic in all over the gray matter, and this severely reduces in the UWS patient. The brain connectivity was also found to be reduces significantly that we see in the EEG as well as in the functional MRI. So the connectivity gets reduces globally as well as in the specific areas such as default mode network. Along with the function, the structure also found to be reduces in loss of consciousness, like UWS compared to MCS, and the perturbational based approach like auditory task or the direct perturbation of TMS EEG shows brain lose the complexity, spatial pattern, and the neural propagation in loss of consciousness. Along with the different multimodal approach, there have been also some theoretical framework proposed to explore the consciousness, such as the integration information theory, which proposed the amount of information integration happen in the brain is indicate the degree of the conscious level. The other is the global neuronal workspace theory, which represent the different brain functional model carry the information together for conscious process or conscious perception. More towards the clinical content, there is an internal and external network which proposed that brain have a specific area which relay for the conscious process, and there is a two main network, which is internal awareness network, which consists by the midline posterior cortex and anterior cortex, and the external network, which is basically the frontoparietal area. The internal network represents the internal awareness, whereas the external network represents the external awareness, and loss of brain connectivity or activity within this network or between this network causes the loss of consciousness, or hypothesized to be have a lower consciousness. Another important framework is the major circuit hypothesis, which says brain have a certain area which form a loop or form a circuit that thalamus excited or inhibit the cortex, specifically to the midline posterior or anterior area, and this inhibition or excitation of the thalamus to the cortex forms a loop, and breaking down or have a reduction in this loop, the excitation or inhibition may cause the loss of consciousness. So the main theory, what all theory have proposed, the main pillar or the main concept of these theories are information integration and processing, the cause-effect structure, and spatial-temporal properties and role of brain region. So if I just recall you in the previous slide, that the global connectivity or the global structural changes doesn't provide a direct information of this concept. So a clinical need is we know that during loss of consciousness, the brain function is reduces significantly. However, it's important also to understand the fine-grained satisfaction of different level of consciousness, and to develop indices or to have indices that will assess the underlying structure of this loss of brain function, which not only help for diagnosis, also help to understand the mechanism of consciousness that will help for the clinical content, as well as it provides some scientific relevance with the philosophical importance. With this need and previous studies, my PhD, in my PhD, I studied the neural dynamic of DOC patient using multimodal imaging and computational approach to characterize the underlying neural structure of this severe reduction of the brain function, and to provide the mechanistic explanation of loss of consciousness, what we observe in the cerebral activity. Then to conceptually bridging the observed neural dynamics with the theory of consciousness. Before I go to the mechanism, first I looked how the multimodal neuroimaging helps to understand, helps to characterize the non-behavioral sign of consciousness. So in the chapter 1, I looked the non-behavioral sign of consciousness using multimodal and brain topological approach. As you remember, I have told you the patient after facing the severe brain hemorrhage or brain damage, patient lose the awareness and awakeness, and the cognitive motor function is called coma. And when the patient recovered the arousal, but it doesn't show any sign of behavioral sign of consciousness, is UWS or behavioral sign of awareness. So some patient who doesn't show the behavioral responses, but they have some amount of preserved brain activity. You could see here the patient who are behaviorally through CRS or test, they are classified as a UWS patient, but this patient have some amount of preserved brain activity, which was seen by the FDG PET. And this indeed we hypothesize that this preserved the lower amount of preservation in the brain activity could support consciousness. When we looked their outcome, this MCS patient, star patient had a better outcome. 31% of the patient showed outcome after 1 year, whereas the truly UWS patient does not show any outcome. This indicates this MCS star patient have a significantly different than the truly UWS patient. So we try to characterize the non-behavioral sign of consciousness or the MCS brain dynamics using quantitative multimodal assessment for these 3 clinical sets. So with this end, we selected from our database, from our multimodal database, the 175. In our database, we had 175 DOC patient, and with the inclusion criteria for having we took only the chronic patient and the patient who have more than 5 CRSR and adult have more than 16 year of more than 16-year-old, and finally we had the 135 patient. So out of this 135 patient, we through CRSR 87 patients are MCIS and 48 patients are UWS patient. Then for again we classified using the PET SUV visual inspection. Out of this 48 UWS patient, there was a 32 MCS, 32 UWS patient who have a metabolic activity, and we categorize as a MCS star, and 16 patient who didn't have the metabolic activity. And then we looked their brain dynamics using multimodal neuroimaging. We looked at the EEG connectivity, and through structural MRI, we looked the gray matter volume loss, and through resting state of fMRI, we looked the functional connectivity, and using network theory measures through EEG and functional MRI, we looked the brain network integration and segregation. Through PET measure, we looked what are the brain region having a higher differences in the metabolic between the MCS and UWS. MCS star and UWS, and we also quantified with a metabolic index called metabolic index for West hemisphere by normalizing the metabolic values. So as a result, we get one global value for whole brain metabolic activity. We from this multimodal neuroimaging approach, we find there have a significant differences in the MCS star patient compared to UWS. And you could see here this head plot depict the EEG functional connectivity, and the arc and the color represent the strength of the connectivity. We find the MCS star patient have a preserved alpha connectivity and suppression of delta connectivity. This preserved alpha connectivity and suppression of delta connectivity have been previously shown that marker for conscious level through UWS patient compared to the MCS patient. Looking on the gray matter changes, we find the MCS star patient have a preserved gray matter in the frontotemporal area, and when we look the metabolic activity, we find this patient, the MCS star patient, have a preserved frontoparietal metabolic as compared to truly UWS patient. And when we quantified this metabolic value as an index for frontoparietal network, and interestingly, you could see this metabolic index is separating the UWS patient from the MCS star patient, as well as with the MCS patient with a number or with a threshold of 2.7. So it's clearly indicate this group MCS star are different from the UWS, and it's also open biomarker for potential biomarker for clinical practice. So the frontoparietal and temporal gray matter and functional connectivity goes in line with the external awareness network hypothesis, which suggests that the loss of consciousness in the external awareness is causes the loss of conscious level. Then we looked how this functional connectivity is altering the brain network properties, and we find through EEG they have an increased alpha degree, which represent the brain connection and alpha participation coefficient, which represent the brain network integration. So in MCS star patient, we find the higher brain connection and network integration. This also was noted by functional MRI. We find the MCS star have a higher integration and lower segregation and efficiency. So this indicate the higher capacity of integration correlated with the higher conscious level. So this measure have been previously also demonstrated in MCS and UWS patient. And this measures are found to be a robust measure. And here we are showing that this measure not only differentiate the MCS and UWS, it also have the potential to differentiate the non-behavioral sign of consciousness patient, which we call the MCS star patient. So these are quite robust method, but it doesn't provide enough to explain the conscious or loss of conscious process. And to understand more in depth of loss brain dynamics in the for loss of consciousness, one approach is to understand to assess the brain spatiotemporal functional properties and how it is associated with the underlying structural connections or structural networks. Indeed, previous study by Athena have shown that the spatiotemporal functional properties support consciousness, and they have shown that the UWS space, the brain have a different pattern, and the pattern which have a complex long-range connections have a lower in UWS patient compared to MCS and healthy control. And the pattern which have simpler or lower connections have a higher in UWS patient compared to MCS. It's also been in one of my previous study, I also shown that in loss of consciousness through propofol sedation, some brain region like PCC, the posterior cortex, it reduces the connectivity and is the temporal fluctuation of this reduced connectivity also lower, and some brain region like thalamus having increased connectivity, and when we look to the spatiotemporal properties, it have a higher temporal fluctuation compared to the rest period or baseline period. Then looking on the functional association with the structure, the study also have been shown that the complex long-range connections have a lower correlation with the structural matrices in UWS patient compared to healthy control, and the pattern which have a simpler lower connection is more in UWS patient. The correlation with the structural matrices have more in UWS compared to healthy control. Looking our own data also, we looked how the structural connectivity matrices is correlating with the functional connectivity, the static functional connectivity matrices. We find the UWS patient have a higher correlation of structural matrices with functional matrices as compared to MCS and healthy control. This indicate the in loss of consciousness, the UWS brain are higher structurally constrained. They have a higher similarity of brain functional network with structural network. So it's important to understand how this spatiotemporal functional repertoire is altering, and how this spatiotemporal repertoire is driving or associating with the anatomical connection, the anatomical network. To assess the brain structure function, we selected 16 UWS patients, 30 MCS patients, and 33 healthy controlled resting state functional MRI, and we selected DTI and T1 images, and we assessed the spatiotemporal structural brain functional network state from the resting state functional MRI. We parcellated the brain functional images using a high resolution brain parcellation, which have a 214 brain region, and we extract the time series of this resting state functional MRI, and we construct the dynamic functional connectivity matrices of the time series. And this dynamic functional connectivity matrices we use along with the a priori resting state network, which is the classical sensory-motor network, frontoparietal network, default mode network, subcortical network, sensory cellular network, and visual network. So we use this dynamic connectivity and the network in the non-negative tensor factorization analysis, which is a higher order principal component analysis, and this provide the underlying spatial distribution of the network. So which provide how the network which we provide is spatially altered and how their temporal fluctuation is there. And the temporal fluctuation we measure in terms of dwell time, which present the amount of the rate of amount a network is present, and the non-stationarity. We also look the metastability, which is whole brain spatial temporal fluctuation, provide measured using the standard deviation of synchronization pattern through Kurumov order parameter. Then we also looked how this temporal fluctuation, the functional repertoire is associated with the underlying structural connection. So to do this, we use the DTA connectivity matrices, and we parcellate the DTA connectivity, using the same 214 brain parcellation, and we construct the structural matrices using the streamline count between pair of brain region. Then we use the eigenmode, which provide the underlying structure of the structural connectivity matrices, and we do the fitting between the dynamic functional connectivity matrices and the eigenmode, which provide as eigenmode coefficient that explain how the functional repertoire is having the association or the harmony with the underlying structural connections. From this spatial temporal properties, we find using the non-negative tensor factorization, we are able to find the spatial distribution of all network, and we mark there is the classical network of default mode network, visual network, salience network, posterior DMN, frontoparietal network, and subcortical network. Important thing to be marked here, we given as a priori the subcortical network, but it comes with the frontoparietal temporal areas. So we give only the thalamus, caudate, putamen as a network, and it comes along with the frontal, parietal, and temporal region. This indicates that the subcortical have a strong association with the frontoparietal and temporal region. And the thing to be noted here, the sensory motor network is disappeared from the system, from the output. That indicate the sensory motor network spatial temporal properties was very low in all the group. Looking on the temporal properties, we find the dwell time it reduces in some of the network. So the dwell time represent how much a network or a state is present or is active across the time, or the occurrence, total occurrence across a specified time. So in our case, it's a 10 minute of functional MRI data. And we see the presence of the dwell time is lower in posterior DMN, in UWS patient, frontoparietal network, and the frontoparietal temporal network with subcortical having a very low dwell time in UWS patient as compared to MCS and healthy control. When we look the non-stationarity, we find many network have a lower stationarity in UWS patient, compared to the MCS and healthy control. One important thing to be noted here that the default mode network doesn't show differences between the healthy control and DOC patient in dual time, but it have so the big differences in the expression. So that indicate what we are seeing the bigger drop in the functional connectivity, that this network presence is there, but it loses the stationarity. Indeed, the default mode network is one of the important network in the brain to integrate with the different network or functions. So the appearance is still there, but it loses with the expression for which reflect in the whole brain level. And another important thing is the frontoparatal dual time and expression. From the network which comes separately with subcortical, it have a significant difference between the healthy control and DOC patient, as well as between the MCS and UWS patient in terms of dual time and in terms of stationarity. So that's indicate that the subcortical, frontoparatal, and temporal network is a important network to conscious process or the conscious level. This goes with different conscious theory, that major circuit hypothesis, which postulate that the subcortical area, specifically the thalamus, globus pallidum, is inhibitor excited to the cortical area specific to the midline frontoparatal, midline posterior, and anterior cingulate region. And you can see we have when we look the spatiotemporal properties of subcortical network, it comes along with the frontoparatal and temporal and the anterior cingulate areas. It also goes with the global neuronal workspace theory, which postulate that various different functional module together carry the information for conscious process. And we see here there is the network which affected higher or have a higher differences in unconscious and conscious minimal conscious state is the network which have a higher brain region along with the subcortical area. It also give the insight to the internal and external network. So the external network is drive or have an association with the subcortical area, and the internal network lose the loss of stationarity, but still it's present. Further, we look the spatiotemporal functional repertoire in the whole brain level using metastability and ignition. Ignition is represent the capacity of neural propagation. Is measure the influence of spontaneous occurring event with a network. So to measure this, we first compute the spontaneous event for every brain signal. When a bold signal having a higher fluctuate, we consider there is have an event, and then we see how the neural activity is propagating from this brain region, from this event to the remaining brain region by computing integration corresponding to the event. And then like this, we compute for every event and every brain region, and at the end we take the average of all the event and region to get the intensity ignition. We find the brain have a lower metastability and lower intensity ignition that indicate the in loss of consciousness, brain loses the stability and capacity of neural propagation, which goes in line with the IoT and the global neuronal workspace. Then we looked how this functional repertoire have an association with the underlying network connection. You have maybe remember that we've shown that the UWS patient have a higher structurally constrained brain, and we found when we looked the functional repertoire association with the structure through eigenmode. We find the UWS have a lower eigenmode value, and it indicates that the brain which had a higher structurally constraint, the functional in the functional repertoire, they didn't represent the structural properties of the structural networks. So, as a summary, in UWS patient, the brain have the breakdown of subcortical, frontoparietal, and temporal repertoire. It reduces the brain stability and intensive ignition. The brain, which have in loss of consciousness, have a structurally constrained and lower association with functional repertoire. This spatiotemporal properties and its association with structure provide the underlying properties of altered brain function in loss of consciousness, and it's also shows the link with the different conscious theory. However, one thing which we are lacking here is causality. Indeed, in the various conscious theory have been proposed that the cause-effect structure is one of the important factors to understand the consciousness or to explain the consciousness. So we studied this cause-effect structure using a computational model. So in the chapter 3, we looked the neural propagation, complexity, and spatiotemporal causal interaction. The empirical studies of auditory stimulation based on the auditory stimulation and direct perturbation through TMS EEG shown that the neural propagation get disrupted in unconscious state, and the brain spatiotemporal causal spatiotemporal complexity is also reduces. You could see here the study done by Fairview that it shows that the auditory oddball task control have a complex P100 and P300 component, and this auditory component, ERP component, reduces in UWS and MCS patient. And the TMS EEG have been also shown that the propagation to the direct stimulation, the TMS stimulation, the complexity and neural propagation is reduces in the loss of consciousness or in the UWS patient. There have been different theory also suggests that the neural propagation, complexity, and spatiotemporal causal interaction is a key factor to understand the consciousness. We take this idea to resting state functional MRI using a high spatial resolution resting state fMRI, and we studied the causal spatiotemporal interaction in subcortical area and cortical area, and we try to understand the mechanism of this disrupted neural propagation, which we see in the empirical perturbations. To understand this spatiotemporal causal interaction, we used in silico based computational model where we use the resting state functional MRI data and DTI and T1 images, which we have selected in the which we have taken in the previous study for spatiotemporal repertoire, and we use the structural connectivity matrices and the functional connectivity data. The resting state functional MRI data, we create the static connectivity with 0 lag covariance and dynamic connectivity with 1 lag covariance. And we also use a model with a multivariate one-stem Allenberg model, which provide how the noise signal is propagates. So we generate the model covariate matrices, and we fit this with the empirical functional connectivity matrices, and we get the estimated whole brain effective connectivity matrices. And this whole brain effective connectivity matrices represent how the neural propagation is happening after in silico perturbation, having the temporal properties that tau, the time constant, and the Jacobian model. We also able to see the spatiotemporal properties of the effective connectivity, the network responses across time and across space or across brain region. Using this computational whole brain modeling, we look the effective connectivity of healthy controlled UWS and MCS patient. Visually, it's difficult to see the differences. But when we assess the difference of UWS patient with healthy control using a t-test and Fourier correction, we find in UWS patient there have an increased effective connectivity links between region, and they have a decreased connectivity links. Whereas in the MCS patient, there is only decreased connectivity. Previously, also study have been shown that UWS have a both hyper and hypofunctional connectivity using normal Pearson correlation. So to understand further for this increased effective connectivity or the increased hyperfunctional connectivity, we look the consequence of the spatiotemporal properties of the effective connectivity. So we look the spatiotemporal causal interaction or network response matrices to the in silico perturbation. So the effective connectivity matrices, which it's this network response matrices represent after perturbation how the brain regions are responding, or how the neural propagation happening after perturbation, and this neural response is how revolving across time. So you could see here this neural propagation or network responses slowly increases and slowly reduces. So you they have a lower neural propagation at the late period compared to the early period. When we compare with the GOC patient and the UWS patient, have shown that certain or higher network responses in UWS patient at very early time compared to the healthy control, and this increased network responses goes very fast. And you could see here in the late period, there have a very less network responses compared to the late period. And this was quite evidence when we looked the whole brain network responses. So the whole brain network responses was computed by taking the average network response across all brain region. So we average the whole brain region and we see how it is revolving across time. And you could see that different patient group have the MCS and UWS patient group have a different network response. The UWS patient have a sudden increase of network response, and this sudden increase goes very fast. This indicates the UWS patient have a lower capacity to propagate the neural activity after perturbation or after the event. And what we were seeing in the higher connectivity or increased effective connectivity in UWS patient that that explained here, the increased effective connectivity was due to the increased network responses. But this increased network responses goes very fast. That indicate the brain doesn't have the capacity to carry this neural response or network responses. When we look the MCS patient, this have a similar pattern to the healthy control, but have a lower network responses. This indicate that in the reduction of consciousness, the brain have a lower capacity to lower network responses. having the effective connectivity. This you have been seen that this matrices is asymmetry matrices. So due to the asymmetry nature, we can assess the brain region in terms of broadcasting or receiving in terms of causal properties. So the broadcasting is after stimulation, how a brain region is broadcasting the information to remaining brain region. So it is the information outflow that one node propagates to the rest of the node. And the receiving information is the information inflow that converges or that arrives to a node from rest of the brain region. Then we look how the brain network responses across time is revolving with broadcasting and receiving information flow. So we plot the temporal revolution of the broadcasting and information receiving for every brain region. So here all the curves are 214 brain region, which shows the network revolvement for broadcasting and receiving. And you could see there some brain region having a higher broadcasting and some brain region having a higher receiving capacity in healthy control, whereas many brain region is have similar broadcasting and receiving capacity. And this brain region, which had a higher broadcasting or receiving capacity, was reduces in the loss of consciousness, specifically in the MCS patient. And this further goes away in UWS patient. So this explains what we were seeing in the empirical TMS induced network responses, that the complexity and network response, which the disrupt network response and complexity was could be due to the brain region, which have a higher capacity for the broadcasting and receiving. And as the region which had a higher capacity of broadcasting and receiving goes away, the brain have a simpler or the complexity also gets reduces. This goes in line with the conscious theory that the amount of information integration is with which correlate with the conscious degree of consciousness, and there have a different functional area which together carry the information processing. And you could see there have some area which is higher in receiving and some are higher in the broadcasting, and coordinating with this broadcasting and receiving is goes with better neural functions. Then when we look the brain region wise, we find there have a specific pattern which get lost for the broadcasting, and you could see here the for broadcasting it is basically the subcortical area and the midline and the temporal area, which goes in line with the global neuronal workspace and major circuit hypothesis, which suggests that it's a many functional area, and the subcortical area, which increases the brain, which get breakdown in the loss of consciousness. On the other hand, the receiving capacity is mainly on the posterior region, is the PCC and occipital, which goes in line with the IIT that the posterior region have a sensitive to information integration. And so if I in all my major studies, on the case study, my contribution was to understand how the underlying structure is get altered, or the which we see the higher reduction in the brain function, and to provide the indices that to assess the underlying dynamics, as well as to help for the mechanistic understanding of mechanistic of cerebral activity observed during unconscious state. So looking on the all of my three major studies, I conclude that spatiotemporal causal interaction is a potential measure to not only differentiate the different conscious states, it also provides the mechanistic understanding of cerebral activity observed during unconscious state. Indeed, the recent theory of temporal integrated causal land space also proposed that the multi-direction of understanding is give the better explanation of consciousness. And we also observed that the brain stability, integration, capacity of neural propagation and information processing is get lost. The brain having a higher structurally constraint and lower association with functional repertoire. And more looking on the spatial pattern, there have two things which we observed in the chapter 1. You have seen that the gray matter loss in the temporal frontotemporal area and the metabolic loss in the frontoparietal region was that we provide the how or what are the alteration happening in the underlying in terms of different spatiotemporal repertoire, and we find this region have a loss of functional repertoire in terms of dwell time and non-stationarity, also have the reduction of neural responses. And this functional frontoparietal is given or have association with the thalamic or subcortical part. Further, this network have a loss of capacity in broadcasting the neural information, which goes in line with the global neuronal workspace that multiple brain regions together carry the information, and the major circuit hypothesis says that the thalamus is inhibitor excited different brain region. Looking at the other side, the default mode network, which is the key network for consciousness, we find that this network is lose the stationarity, but is still remain and have the lower capacity of receiving in the posterior region, which goes in line with the information integration theory that the posterior part is highly sensitive to integrate or to converge the information. Also, our result is provide the explanation of internal and external network. That external network is lost the functional repertoire as well as the broadcasting capacity, and internal network lose the non-stationarity and receiving capacity. These different measures are in line with different conscious theory. So here we are not providing which is more valid for more potential conscious theoretical framework, but we show that these theory have a shared element and complement to each other like two sides of one coin. And the metabolic index and network integration could be used as a complementary for clinical evaluation. These are the output of the PhD work. Some are under revision. And I have been also working with my colleagues in different other projects. And other than the DOS patient, I also work in the other altered state of consciousness like apnea and hypnosis, meditation, and virtual reality. I should say the work which presented here is the teamwork and should not be considered as a individual. I wish to thank Steven Itka for guiding me, and the computational work was done with collaboration with the University of Pompofabia with Gustavo and their team. Thanks to Gorka, Anne, and Matthew. I also wish to thank Prash Tiwari, who helped in the dynamic connectivity, and Sebastian to helping me in the EEG and the MOG. I also thanks to my professor who bring me or who given me the path to come for research, is Dr. Tapan Gandhi from IIT. And I also wish to thank all my colleagues from Coma Science Group for helping me in the professional as well as in the other stuffs. Yeah, and plus I used to thank my funding. The PhD work I funded from HBP and FNRS. Thank you.
Thank you, Raja. We had a lot to say. I should have mentioned that everything has to be wrapped up also within 2 hours. I hope you still have something to say to the jury members. Has Professor Biswal been able to join the meeting online?
Yes, he joined, but I think he doesn't have the rights. He's not a presenter. Should I change that? I see only Stephen.
To see if he has questions.
Yes.
Is he hearing things?
I think he's hearing everything. Yes.
I hope so.
No, I mean.
That would be a bit more
My
interesting.
the contact I had with him, he was hearing everything, but
He can't speak.
I see that he's not a presenter, and also the chat is
It doesn't have to be a presenter on Teams to be.
Yeah, but neither the chat is working, so I don't think anyone can. Well, we can try. I mean,
Just
we can ask.
So yeah, in out of habit, we start usually with jury members further away based on geography and location of the candidate. So that would be Professor Biswal.
it's just 1 minute.
Hello, Stephen here. Can you hear me?
Hi.
Yes.
Hi. Can you hear me?
Yes, very well. Thank you so much.
Thank you. Sorry for being a few minutes late. So I guess I should ask the questions first.
Yes, Professor Biswal, you are the first one to roast the candidate.
All right. So first, Rajanikant, really an amazing piece of work. Really, the results are really good, and I'm pretty sure it will be used for not just consciousness, but for other disorders as well. But I had like a few questions, like some, perhaps I'll first mention the technical questions and then perhaps some applications. So for technical questions, one was that you used a number of different models to test your hypothesis, and then you came up with some results. So one question was, how did you decide which model was better compared to the other models? So that was one question. The second question, I think I had asked in the previous private one, is that with the lesions, are you did you just explain briefly what kind of steps you did for pre-processing? And I think those are the first two questions. I'll wait for your answer before I ask the other one. So maybe start with, how did you decide the model order, or which model to choose?
Yes. Thank you, Professor Biswal. I just take 1 minute. There is some problem which get hanged the presentation. So.
Maybe just explain it.
Yes.
Here it is.
Yes. So, yeah, in the to your answer about which model why we have used a specific model. So our, as you have seen here, we shows the multimodal neuroimaging have shown that the loss of brain functions, and our interest was to characterize the underlying structure of the this severe reduction of the brain function, and based on different conscious theory, there have been proposed that the specific concept is important for the conscious process, that is information integration, the causality, or the spatiotemporal properties, and the role of brain region. So here we try to use or we use the model of which have which able to assess all different properties, such as like which assess the spatiotemporal, which assess the causality, and which assess the neural propagation and information flow. So first we use the static and dynamic structural functional repertoire, but in the conclusion I conclude that the best which we believe or which we think that a potential measure is a spatiotemporal causal interaction indices, which is the whole brain network responses, because this measure is for three things. It is able to distinguish different level, the MCS and UWS. It is giving more what we looked in the whole brain, it is giving how the neural propagation is getting altered, how the causality is happening, getting altered, and how the brain regions are interplaying or having the different properties. And the third is we also correlate that spatiotemporal causal interaction indices with the PET metabolic index. So let me in the so this is the whole brain network response, which we correlate with the PET metabolic index value, and we see they have a higher positive correlation with the network response and MIBs. This indicate that the computational measure which we do is also have a association with the brain functions. So considering all three factors, that this measure providing multi-dimension of the altered brain function and able to distinguish different conscious level, we suggest this is a good a potential measure for conscious study. And for your second question regarding the analysis, we used here the FSL-based analysis, where we used the ICA to regress out the noise. So we used both SPM as well as the ICA approach, and we finally used the ICA approach because it is allowing to regress out the effect or the noise, or not regress out, but suppress the effect of the cardiac and respiration, as well as the lesion specific. So I wish to mark you this patient have a higher brain damage and or gray matter. Even if we include the patient who are having preserved brain or the partialation happen properly, but they have a certain amount of gray matter alteration. And then also I wish to mark, as you pointed out, the structural changes. Professor Vishwal, are you able to see my screen?
Just only half the screen. But I think it is okay. I think in your thesis, you have described about ICA and how and what you did to process. I think that is fine. So the other question I was to ask was that in terms of static functional connectivity and dynamic functional connectivity, one has an intuitive feel about what it is, so one can explain it fairly well. In terms of graph theory, like when you say, as you observe that, let's say, clustering coefficient in coma patient is higher or lower, can you explain what does it mean physically or physiologically?
Yes, thank you. I wish to also ask you again for a few minutes. There is again the disconnection which happened with the PPT.
Can you just reply with the slides? Just give the ideas and the explanation.
Yes.
That would be sufficient.
Right.
Yes.
I agree.
Yes. So we have looked the graph theory measures, and as I have proposed that our interest was to understand the connectivity differences. We looked the network topology, how the network is altering in terms of the brain integration, in terms of the brain network integration or brain network segregation and efficiency. So this graph theory measure, which like clustering coefficient, this shows how the brain network, the connection which was measured in the observed functional connectivity, how this having a forming a cluster or forming a segregation within the network. And this indicates how well the brain functional models are getting segregated, and how this segregated functional model are interconnecting or having an interaction within those models that indicate the brain network integration. So looking in terms of the network measure, the network integration and network segregation, it provides one step further what we look in the severe reduction of the functional connectivity in DOC patient, and specifically on the loss of consciousness or in the DOC patient, we see there have a decreased integration which and increased segregation. So this decreased integration is represent that the in loss of consciousness, the severe loss of functional properties what we observe, it reducing in the homogeneous way, all the link getting reduced in the homogeneous way, and even if it's forming a higher network segregation, but those network segregated network doesn't coordinate or doesn't have a interaction between those networks. And second thing is also the lower connectivity forming as a one or two network. So that's where we see the network changes in the DOC patients.
Thank you, Rajanikant. So, like, if I could ask one final question. So if I was to, having read your papers and your thesis, if I was to choose a different disorder, a different patient population, could you suggest something? Do you think it would be stroke? Do you think it would be aging? Do you have any suggestion as to how we can use these results in a different population, and what population do you think would work well?
Yes. So one is, as we have shown, that this measure is quite potential for the disorder of consciousness or the pathological unconscious state. To be noted here, we have analyzed only the, or we have looked at one aspect of pathological unconscious state, which is disorder of consciousness, but there is a different other disorder of conscious or the impaired consciousness, such as the generalized epilepsy, where a patient lose short period of consciousness, and it is also affect the whole brain when the patient having a seizure, or when the interact, it can also happen. So I think it is quite a potential measure to also study in the epilepsy, and not only in the generalized epilepsy. I think all epilepsy, the consciousness is get hampered. And in other also, like the schizophrenia, where consciousness is altered, or it carry with impaired consciousness. So this measure also could be a potential to study the altered brain function of schizophrenia patients. So this is with respect to the consciousness, but I think this measure will be potential for neurological disorder, because in neurological disorder, patient like in the stroke or in the in the movement disorder, after progressing, there is treatment through medicine, or through the therapy, through the therapy procedure, not with the surgical procedure. So to understand which patient will be having a better outcome, or which patient can be respond to a therapeutic procedure, I think it will be good to understand the underlying structure. So how the brain, what we observe in the global level, how it altering in the underlying structure, how it is affecting. So I think this will the measure, the spatiotemporal complex index measure, could be also useful in the different neurological population.
I think that is all the questions I had for now. So
thank you. Thank you, Professor Biswal. Now we move to guests.
Can you see this?
Questions, comments?
Yeah.
Can you please just help me?
First of all, congratulations again for the presentation, and the main technical details and remarks that I had expressed them in the previous events. So we'll not go really too much into this again. More so in the link between your results and the theory, particularly the two theories of integrated information and global workspace. So they are both centered around the concept of information. And so, for example, if you go to your perturbation study, and you don't have to do that, just keep it in mind. So you were talking in the conclusion of this work, for example, that you had some regions or which displays differences in broadcasting and receiving neural information flow. This is what the word is used. So these conclusions were based on results in which you basically take the covariance matrix of the whole field, and then you model onto it a dynamical model, which is not even biological or so. So how would you make the link between covariance matrix of both activity and broadcasting and receiving of a neural information flow?
So we used here a computational model of which use the in silico perturbation. So we use MOU process, which is the signal noise propagation, which using this we estimate the effective connectivity, So this is, I agree with you. This it is not direct to the physiological process because it's not that inhibition or excitation properties or the hemodynamic response, but by estimating with statistical process, we able to see how the brain regions are propagating the neural activity or the bold activity from one region to the remaining to the other region, and this neural activity propagation that we we are assessing in the brain region wise by looking the causal or the looking the directionality. So as we have the model as providing the effective connectivity, and by using the temporal features, the bold constant and the Jacobian model, it's we able to see how this causal or how is the directional matrix is revolving across the time. So this revolution across the time and the directionality, taking consideration of this both using the network theory, the what is the participation coefficient, and using the network theory, we able to capture how the brain is propagating activity from a region to remaining region, and that we take as a receiving broadcasting properties. And we look also how different brain region after getting perturbed, how it is sending, or a brain region, how it is received the neural activity. So it is the neural activity that we assess in the statistical and computational model. And in the study or the model which we were trying if we could combine the hemodynamic response function, but it was complex model along with the hemodynamic response function. But in the future study can be assessed. And also combining the direct physiological model, like the direct dynamic mean field model, which provides the inhibition and excitation, combining the model which we have, and with this dynamic mean field model or the information theory model, like transfer entropy, we could provide more direct association with the neural response.
Yeah. So still speaking about interactive information and entropy you just mentioned. So there is the data processing inequality, which says that you cannot basically create more information by processing further processing the data. So here you have the covariance matrix.
Yes.
So my question is, it is necessary to do all this type of modeling when from the covariance matrix already have all the information that you need?
Covariance matrix, the information with respect to is the functional
to the data which generated the covariance matrix.
Yes. So we actually have the covariance, the empirical covariance matrix with 0 lag and with 1 lag. It's with the temporal properties, and we have the model. So we fit both what is covariance matrix with the model, the MOU model, and the estimated or the output of the matrices is the best fitting of the empirical covariate matrix, which is direct measure of the functional connectivity, and the model. So it is represented not only the neural response or the signal noise propagation, it also have the association of the functional covariate matrix. So the functional covariate matrices are fitted with the empirical model.
And when we talk about networks, typically there are two main directions in which we could refer. So either we refer to network as collective behavior. So non-parietal network regions which do things together. Or we can think of a network as a pathway to go from one region to the other with a physical link. So in your studies, to each of these two possibly complementary definitions you feel closer?
So yes, I wish to show you one actually.
Also in view of the two theories you are inspiring yourself.
Yes. So here the matrix which we get also you could see that the early states having the higher what is diagonal the matrix having the higher cluster or the diagonally is more cluster and the
it's more a general question.
Yes.
To when you mentioned networks in all your book, what do you refer to?
It's referred to the brain network integration and which could be also the path length. The path length is the absolute path length is represent the brain network integration.
So is the path what works or drives or flows on the path?
Yes, the shortest path between two regions.
Yeah, but who is the actor which uses those paths?
The neural activity or the observed neural activity in a specific.
So like the electrical activity flowing or?
Not the electrical activity. It is actually we measure the Bol signal or EEG signal, and we see the what is statistical coherence or the statistical relationship on this network, and we express the network integration or network segregation on the statistical and brain region relationship.
So you think that the notion of a path, so for example, there is if you say there is a path between the dorsolateral prefrontal cortex and the insula,
yes.
Can a path be assessed by statistical advances? So let's say, we understood that it's not a physical path, but you can say that there is some information that flows from one region to another, and you can assess this by statistical advances, which is a full matrix, and then you cut some links, and then you say that the rest is the path.
Yes, yes,
okay.
Yes. That is actually we first constrain the structural part, and we only see the effective connectivity, or we see how the brain influence when they have a structural part.
I think it's a very wide guess, but if you believe it, then it's fine.
Here actually two things. One is the taking whole brain region and to see the effective connectivity, or to for the causality of all brain region. It is complex, and in the other hand, it is like what is to the where if they have a structural path, it have it should have the information flow. So it's not.
I was referring also to the other side in which the path is built on the scalp, where basically you have distribution of electrical activity coming from inside the brain, and then it's on the scalp, and then you have some sensors which can be 20, can be 60, can be 250, until this becomes the node, and there is a path among those.
Yes.
Okay.
No, sorry, it's not this. So actually, we measure in the scalp level, and as you suggest, yeah, it is a big problem when we in the network field, it is the brain region. We look the network in the brain, but the EEG connectivity is the scalp level. So here, it is not the direct approach, or it is not the recommended approach that we look directly in the scalp level. But when we look the global or the whole brain features, so even if they have a volume conduction issue in the regional level, but the global will be giving the potential information. And as you've seen here, we also did in the functional MRI, and it goes with the functional MRI. And in fact, our colleagues also have looked the EEG source reconstructed data, the network theory, and they also shown that the alpha network integration reduces. So as the scalp level network properties are in line with the source level and with the functional MRI, we can suggest that in the global level, in the whole brain level, this may just still providing a valuable information. But I agree with you that network theory in the scalp level is we have a lot of bias.
Thank you. No more questions? Yeah. Okay. Perfect. Now we move to Liège, the CRC. Mohammed, who wants to go first?
Thank you. So, first of all, thank you, Raja, for this nice presentation. I also would like to thank you for the effort of compiling and applying all these methodological development, which provides us with the possibility to assess and to better understand the let's say states of disorder of consciousness. So, thanks to this development, clinician would surely benefit in the diagnosis of such patients. So, regarding the question asked before me, I see my list shortly. So, the two, let's say, remaining questions that I have are related to the preprocessing. They are purely technical questions, let's say. So the first one is for the fMRI data preprocessing. You use the FSL with ICA-based denoising method for reducing noise and improve the resting state network analysis. The computation of the, let's say, the component was done using melodic model. If I will understand, the identification of the bar and the component was done by visual inspection. So here, you know that manual intervention often leads to errors. And in this case, probably we could miss some main signal from the data. So my question would be if there is or there are any other alternative which could avoid such errors.
Yes. Yes. So yes, the independent component is assessed by the visual inspection, and specifically for the fMRI, or both in the EEG and the fMRI, it is quite challenging to assess which is a noisy component, and sometimes we doesn't remove the noisy component, or sometimes we remove the component which have a physiological. So to avoid or to reduce this bias, we actually two person in the publication we wrote this, but so two engineers who independently we assessed the ICA, and the ICA which was having the differential view that it is noisy or it is not noisy. Then again we both together sit and we discussed with looking on the spatial pattern, looking on the temporal pattern, and with the power spectrum, and decide that. So it is up to one level is the reducing the bias. So and it's suggested that for the fMRI ICA denoising, there should be 2% to visually inspect. And the second is the fix. So we have actually used fix, but for the training. So in the melodic, there is a tool for fix, which first it's the noisy component should be visually inspected and visually marked. Okay, which are the component for cardiac, which are the component for respiratory, and which are the component for the lesion. And after having certain subject like more, there is not number, but let's say a higher number of sample after training, then automatically it detect okay which IC is having the noise. But still, after automatic detection, it is important to visually inspect. So in our study also we use fix and we use the visual inspection with the two engineers.
So my second question is also related to ICMU decomposition. I see that you have chosen the use the automated dimension estimation.
Yes.
Which probably can lead to additional component. I mean by that, sometimes the network you will find it split in different components.
Yes.
And here the question. First, if you face this problem, and if yes, what steps have you taken to avoid this additional component or to handle this additional component?
Yes, yes, we face this problem when we give the automated dimension reduction, specifically in the DOC patient. When in the healthy control, there is like a specific number, more average specific number of component. But in the patient, if a patient specifically move or have a higher atrophy, and the physiological network, like the default mode network or the frontoparietal or sensory motor network, is get divided over multiple times. So that limitation or problem is there. But here we were only selecting the noisy component. So even the noisy component is get multiple component. It was not an issue. And so we only focused on noise component. But other than this study, when we do ICA in the group level, we always use a specific number of ICA decomposition based on the previous study. So I think it is the 30 number of component, and it is also quite recommended that we use a different set of ICA to see if there have functional network is not getting divided. So if it is getting divided, either we use the lower number or higher number to see the main network component, default mode network, essentially all the classical resting state networks will not be get supplemented.
Thank you. Excellent work.
Thank you so much.
Okay, then I think that.
Yes. Congratulations, me too.
Thank you so much. Thanks.
Been amazing work. I see it's very productive.
Thank you. Thanks.
You've been doing quite some stuff. I mean, I really like the book. I love it. Concerning the presentation, I'm less enthusiastic. I find it a bit too technical for me, at least. Okay, it's always personal. What I'm missing yet is more the conceptual, the higher picture, the bigger picture, what we understand, what it means. You see this. So I will ask you questions about this. So I understand whether you understand. Some both understand. So I have some comments that they are more technical, some others are more broad, but I will start with the big ones. So I will start by the approach that you choose in the first place. So it's a computational approach to study resource of consciousness. So I would like to ask you, like with this approach, what are the pros and cons And mainly, it's like the question comes down to how this computational work, because it's very representational, very abstract, mathematically based, how it can help us understand biology and at which level. You feel comfortable in saying that after I've done all this work, now I can tell a physician or a clinician, do this intervention, for example, because this will work. So I guess this comes with other previous comments that I've heard, and it comes down to what is the link between computation and physiology or biology. How confident you are to say that you will learn something with the other based on the question.
Thank you so much for the question. So I just so for clinical practice, it is essential, it is a need to reduce the uncertainty of the diagnosis as well as the prognosis and treatment. So for diagnosis, as you have seen that the MCS patient behaviorally, they don't show, but using the imaging, in the static connectivity also we will be able to distinguish, we are able to distinguish the different brain states to the frontoparietal network or the normal metabolic activity in the frontoparietal or the default mode network connectivity or activity can be used to see this used for the different level of consciousness. But when we go for further, as you say, that how it could help for the what is the treatment or outcome. It is essential to understand the underlying structure, how this severe reduction of the functional or the structural damage is altering the functional brain properties. And this brain properties in the multi-dimensional aspect is such as like how it is affecting the spatiotemporal or how the network or specific network, like in the old study we have shown that the subcortical frontoparietal network or the broadcasting of this subcortical frontoparietal multiple module of subcortical cortex is providing the insight to the pathological or to the loss of consciousness. So these can be used in the targeted treatment, like in the Thesis, or to see, okay, how even if a patient has a lower functional activity or complex connectivity, how the complexity or how the spatiotemporal approach-wise alter, and for specific target like Thesis, if there have a complexity in the brain, it have a so that they will have a better outcome or the response to the. So using this computational indices, the computational spatiotemporal causal interaction that also provide the complexity and neural propagation. If the patient have before giving the therapy, it could be guide or it could be help to understand if they have a higher complexity, causal interaction could be work. And
right, these are still computational terms. So I wonder, I mean, whether it has interested you to see, for example, the neural responses, like in terms of neural firing or in terms of neural assemblies, like, something more biological. Can we extrapolate from the computation to biology from this way?
Yes, one thing is in the biological model, like what is to understand the neural propagation or like brain excitation or inhibition capacity. That we could indirectly infer with the information outflow or information inflow. So information inflow having the higher association with the inhibition and outflow is the excitation. So one of actually the ongoing or in the poster we propose that further we'll look the dynamic mean field model combining with this causal interaction So currently is the indirect measure of physiological properties. However, in the future study, we are already doing to combine the dynamic mean field model, which is more biological, with this spatiotemporal causal interaction.
Yes, thank you. Great. So if we stay to the mechanisms again, in the introduction, you advocate in favor of having a good balance between segregation and integration. And you say that it's very important to distinguish cognitive behavior, cognition behavior, and consciousness. And in conclusion, you just skip segregation. You just talk about network integration, spatiotemporal causal interaction, and neural propagation as potential indices that they're more formative. Why not segregation? What happened?
So it's one thing is the brain integration is not exactly directly proportional, but like in our condition, in the pathological morphosis rate, and in the technically the segregation have a inversely proportional relationship with the integration. So when integration is reduces, the segregation is increases. So in the functional MRI data, we have shown this reduction, and in the paper also. So here we need broad because it is first it is redundant because if integration is going down, so segregation is getting will be increases. And second is our here we focus more on the network integration and the information processing. So that's why we, out of these two measures, which have a close relationship, close inverse proportional relationship. So we explain through the network integration.
Because I was thinking like both the theoretical models that you mentioned, they also advocate for the importance of segregation. So it's important, it's like on the one hand, yeah, it's important to integrate information and have like things combined synergetically, combined. But it also a system should know also where to inhibit and start something more different from others.
Yes.
This is at least how I see segregation in that terms.
Yes. So actually, again, we didn't have done the statistical analysis, but so this matrices, which is able to compute in the temporal aspect. So it's actually provide the first when the brain network having a higher cluster up to the moment the clustering is not collapsed to the smaller brain region, it represents the brain integration, brain segregation. So it have a higher segregation in the early period, and in the lower or the late period, when the interaction is in the multiple model and have a connection with the multiple model, it represent the integration. So this we were tried to quantify using network properties, practically how the full up to where the network segregation was higher. So that quantification we don't have, but by looking at the global, you see that have a hyper or a certain increase of network response, which indicate the brain having a higher segregation. The brain regions are connecting to the neighbor regions and doesn't have a connection with the high long range connections, which have a loss of integration. So this indeed this aspect we were lacked, but this aspect could be in future we could go more further to look the integration segregation. Also, it could be used as an index as an integration by segregation.
Okay. My next question has to do with the data. So you use a wide range of data, multimodal data, and there's a certain pool of patients where these data are from. So when you discuss your results, you refer to previous studies showing results that they are also based on the same patients. So my question is like, do we really talk about understanding a phenomenon or do we understand a data set? My question is like, how generalizable are your results?
Yes. So I think it's my, I may be wrong in this point because it is different person have a different perspective on the reusing the data. For me, I think it is to use the data which are previously used, not a issue, because here we are looking the phenomenology, or we are looking the what is consciousness, and specifically to the disorder of consciousness, we get a fewer patients in or for like for PhD 5 year. If I supposed to be use only one subject, the new data, it will be quite difficult. And now when we use data which have previously used in a different study to infer the previous study, this is not feasible, or I think it's not straightforward, because the pre-processing pipeline as well as the pre-processing pipeline is not the connectivity approach, the way they generate this connectivity approach, so the parcellation and the statistical approach the previous study have relied on. When we do it can be done same as what previous study have done, but it is not in that way. We are constraining our analysis based on something previous study. So it is for me, it is like a little bit difficult or a little bit challenging to infer the methodology or the what is previous work. It is to have the freedom for the analysis, and once we find the result and what we observe from the data, then we can go to the different study where the same data have used or not used to correlate.
For example, like there are a lot of colleagues around the world that they acquire similar data, for example. Do you think if you apply the same pipelines, will you find similar results? What prevented you from checking that?
Yes, I mean, we could have checked that one, the same pipeline would have used in the previous. In fact, we have looked it's SPM based on some previous study, including the work also of the 2015 grant paper have used SPM, and we also looked in the SPM and the dynamic connectivity, specifically the which in the computational modeling, we were not getting the function, the result or differences. Then we go through the pre-processing again and we check. So two factors here again. If we are following other paper, there is many steps, and to doing all these things, one is we are lacking. And second things is not completely ignored. We follow the previous work, but not exactly what is every person have their own function pipeline to follow the pre-processing, to follow the post-processing. Pre-processing can be used as the same pipeline, but for the post-processing, and it is. In fact, it is like the dynamic connectivity. If I just look, so in the science advanced paper, we see the complex pattern or different function pattern. But here, our interest was network, how the network is altering. So
how is that relevant for the data then?
So then what we to correlate. So first we're supposed to be done the post-processing. It's not only the pre-processing. So post-processing and pre-processing, we need to follow all the steps, and then to look our aim or what we want to assess. So in such situation, it is what is complex to assess what exactly have done in the previous study. But we take the main steps, and we learn from the paper to what are the challenges. And
No more questions?
Sorry.
Very, like, yes, no, and I guess I know. Nothing on that? So do you consider PWS patients are unconscious? Yes or no?
Yes or no?
Yes or no?
So what I have observed in different conflict activities.
Yes or no?
Yes,
Okay.
it's my perception.
Yeah, no, we
Thank you
have
very
a, sorry, Athena, we have a limit on the time we can spend having fun. So, next. Member of jury.
Yes, thank you. I'll be short. I only have a couple of questions. One is a practical one. And being a newcomer in position, I will focus on the imaging part of the work. So you've been using LDG-based studies at some point in your work. Now there is a new generation of PET-CT devices, the digital PETs, and within the next few years, all the PET scanners will be those new types of PET devices. And the reason why I'm mentioning it is that there is a great improvement in spatial resolution, right? These studies were done with an older generation scanner. So my question is very simple. Do you think that, considering what you are looking at, you know, the biological phenomena that you are studying and diseases that you are studying, do you think that an improved spatial resolution in PET imaging would modify, alter, improve the information that you could extract and use for that purpose? Or it's very important in oncology, spatial resolution. For inflammatory disease, it's important. Do you think it matters for what you are doing?
So I just confused. So it's based on the new advanced, which if the imaging have a higher spatial resolution, can it apply? Or already in the data we could look the spatial resolution?
Do you think that repeating all the experiments using the PET data, but acquire
In the high resolution?
with devices with higher spatial resolution, would that change anything?
Yes. Here we in the paper specifically we look the metabolic activity in the SUV or in the global level, but we assess the frontoparietal network, and we have shown that the frontoparietal network of the metabolic activity or metabolic index is separate in the group, but it's also interest to look the subcortical and in all the study, but you have seen the subcortical area is the important role. So if we have a higher spatial resoluted PET data, then we could precisely see the metabolic activity of subcortical area, the globus pallidum and thalamic region, which surely help on the understanding of conscious state and for the treatment and prognosis. And another thing is the connectivity which is emerging in the field of PET. So currently, if we construct a PET connectivity with the lower spatial resolution, it is having a what is limitation for the against for the spatial lab. And if we have a high spatial resolution and if we have a dynamic PET for multiple time point, even if it's a 6, 7, or I think 10 can be measured with the fast PET, faster PET. So having a dynamic PET and high spatial resolution, we could really look the PET connectivity and the pathway of metabolic activity, which is a direct indication for the biological phenomena. So in future, having a high spatial and temporal PET could help to bring this network theory to the PET field.
Thank you. Just for fun, let's go into the completely opposite direction from Athena, right? And let's say we don't want to understand and we don't want to explain. Right? We just want to diagnose. We want to categorize the patients. We want to a clear, accurate, reliable diagnosis of all the possible various consciousness disorders, and even not disorders, but various forms of consciousness, right? Then what would you think, what's your opinion on just, I can give you a 2,000 normal FDG brain scans and also MRIs, and you could ask Stephen to ask or his colleagues to give you as many abnormal scans as possible, and then you would design a deep learning algorithm to classify those studies, and then it give you an answer. What would be your take on that? What do you think? Is it feasible? Is it desirable? Is it just not realistic? What do you think?
Having a single number or having a classifier, the consciousness is not one dimensional. Consciousness is a multi-dimension and have a non-stationality. So looking on as unique number that to say that okay, the patient is an MCS or UWS. I think from one direction it is challenging, and to have a better diagnosis, it will be potential when we look the multi-direction. So, for example, let me assume we have 1,000 MCS patient and 1,000 UWS patient, and we develop a classifier of deep learning. So, it could be potentially classify the patient with high accuracy, but it will give having a single number for diagnosis is sometimes also that is separates the understanding of pathological behavior, which is important for only diagnosis, not even for prognosis or outcome. So I think for diagnosis also multi-full direction or having a multi-dimension is essential.
Thank you.
Thank you, Roland. Last but not least, on the jury, Olivia.
Yes.
And yeah, we are
late.
We are just in time.
Thank you, Raja. I think you have done a huge amount of work that you presented here today, but also in general, we know that you also work on the clinical duties, analyzing EEG, MRI. You work on other states of consciousness, virtual reality, meditation. So you really did a lot of different work, and you also have a lot of people in the team. So thank you for that. I do have some questions, but if I have to pick one, I would say 1 and 1A again. Among all the results that you show us, what would be the one that you will remember in 10 years or 15 years? So what is the result that is the most intriguing to you, or that you were not expecting? Yeah,
I could say then what we was the spatiotemporal causal interaction in the and the link of the subcortical with the cortical. So this maybe in the I will be taking this knowledge what we have learned in the what is spatiotemporal causal interaction, goes breakdown in the subcortical, thalamic, and the caudate with the specific cortical area, such as the frontoparietal, and also the temporal, which has been ignored in the literature. That we see here, the temporal area doesn't only it also come in the static gray matter changes, functional changes. It also shows in the different sophisticated measures. So this specific pattern, which I observed especially, and the spatiotemporal causal interaction pattern within that network, and that will be bringing to the further with a more biological model. And could be in the 10 years. If maybe there will be an improvement or there could be something different pattern, which could recall.
And so that's my A/B question, is that indeed in most of your studies you show the implication of the temporal cortex, and this is something that as a consciousness researcher we don't often see. Usually it's like frontoparietal and then this analytic posterior area, more like parietal and occipital, and then global normal workspace with the front end, and here in some studies we show the temporal. So any idea why we skipped this area before and now it's showing up in your data?
I think we, in the previous study, like in the Brain 2015 paper, we see the auditory cortex, which have the main temporal region, is the main network to distinguish different functional, different state UWS and MCS. Also, the temporal region could be due to the alteration of, or it could be the impairment of the language and language processing and auditory related processing, which recent study also have shown that the subcortical temporal inhibition in the temporal area have a higher in MCS patient. So in the temporal area, what we are seeing here is have a association with consciousness, and it could be due to also the impairment of the memory process. So this further study could be looked with respect to the language and specifically taking the temporal, different temporal area like superior and middle and inferior temporal to explain more. And I wish to also highlight that the auditory localization, we see the auditory localization have a higher differences in the temporal lobe. So this previous study and what we are seeing here is indicating temporal area is one of the important, and it could be due to the language or this.
Thank you. I had a few questions, but then I skipped them. And then maybe last word to Stephen and Yitka as well. I know that Stephen is waiting for, he has another meeting afterwards. And then we have 2 minutes left.
Thank you very much, Mr. President. I thank you, Raja. Congratulate you. Of course, we need to wait for the deliberation. But already I wanted to share, and we heard it from Olivia, that we all so much appreciate your work. You've been involved in many, many projects. You know so many imaging technologies. Actually, you only showed us a small part of the, 26 peer-reviewed papers you have published, which is quite impressive. You've impressed us today by the quality of your slides and the presentation. You had a lot of challenging questions on a very challenging subject, which is understanding our own mind. So I'm confident that you will be an inspiring scientist. And yet, it's not only about science and technology, is it? It's also about humanity, honesty, humbleness, curiosity, creativity, courage, kindness, passion. And Raja, I think I can speak for the whole team here. You do combine all these qualities. So it's been an honor to accompany you. I, of course, thank Yitka, who will have the final word as the co-director, and the whole team of the Giga Consciousness and the Coma Science Group. And I thank very much your external reviewers and the jury, Daniele Marinazzo from the Department of Data Analysis from Ghent University. Thank you, Daniele.
Thanks, no problem. Next time.
And thank you, Bharat. Vishwal, I don't know you very well. For those who would not know it already, you are at the New Jersey Medical School, a pioneer, I should say the discoverer, really the discoverer of resting state fMRI. So it's been a tremendous honor to have you here. You also illustrate with that reading your historical papers that as a student actually in 1992, you discovered resting state in fMRI. It was considered an artifact. You've proved them wrong, and now we see how it is useful as a clinical tool. So thank you so much. You're an inspiration for us all. And I know also Bindu Kuti from the National Institute of Mental Health and Neuroscience, where you started, Raja, is with us, the director of the Center for Consciousness Studies in Bangalore, India. And I also do believe that your directors from India should be appreciated for their work. So thank you, and Yitka, the final word is yours.
Thank you so much, Stephen. It is really a blessing from God to get your supervision and guidance.
Yeah, Raja, after Stephen's very nice words, there's not much left for me to say. It was a journey that I entered only halfway of your journey. And yeah, I think you've grown a lot. You've been involved in many projects. I really appreciated to see how you deal with feedback, how you manage so many different projects, how you stay kind, calm, collected, how you, yeah, keep going under the pressure. And I hope you will continue to work in the future as well.
Thank you. Thanks a lot. Thank you so much for the jury members and all my colleagues and friends. It's really a great journey.
So our job is not done. We need to move on and have a word. So don't leave. We'll be back in a few minutes.
This time they didn't ask the audience.
Rajanikant.
Yes. Yes, sir.
So we should just wait for a little bit.
Yes, sir. I think you need to connect with them. I'll call to maybe to the.
Hello, Bharat. I will send you the link for the other meeting.
Okay, no problem.
Thank you so much again. Sorry for.
No problem.
Didi. Thank you. Hey, you manage the YouTube? This man?
So, yep, I have your attention. So, I have to read the official document. It's in French. That's the way it is. Monsieur Rajanikant Panda, né à Bhubaneswar, Inde, le 24 mai 1987, subit l'épreuve unique pour l'obtention du grade de docteur en sciences médicales. Attendu qu'il est titulaire d'un diplôme de Master of Engineering in Applied Electronics, délivré par l'Anna University de Tamil Nadu, Inde, en 2014-2015, et d'un certificat de formation doctorale en sciences médicales délivré par l'Université de Liège en 2021-2022. Le jury, après avoir délibéré sur l'épreuve subie par l'intéressé et sur la valeur de la dissertation originale intitulée Multimodal, Empirical and Computational Modeling for Mechanistic Explanation of Altered States of Consciousness, et constaté que les diverses prescriptions relatives à la tenue des examens, au mode de délibération et au mode de collation des grades académiques ont été observées, décide que M. Rajanikant Panda a mérité le grade académique de docteur en sciences médicales. En conséquence, M. Rajanikant Panda est proclamé docteur en sciences médicales. So that's it.